Okay, so we are recording, and which means it is 4 o'clock somewhere. Right, so this is, okay, you may hear a whiny Maltese in the background. I will apologize on her behalf. So this is the third and final lecture that we're going to do on the pediatric context. So let's pick up where we left off. I did post an updated, slightly updated PowerPoint into the module, which just has really more information kind of filled in it. I really recommend writing things down when you're listening. So the more information that's on here is not necessarily helpful. But anyway, here's just some extra stuff. So last time we finished up with depression and unipolar depression. So we're going to finish up this evening with more mood and behavioral disorders, specifically bipolar disorder, and how it gets all muddied up with these other diagnoses. Remember, for the most part, the only anxiety disorders can present in children more than any other, more than mood disorders. Other than ADHD, really, and developmental disorders, those are the only ones that really statistically are more likely to manifest in childhood than later. There's no way that you have autism at onset at 15 or 20, or ADHD onset at 15 or 20. Depression, bipolar disorder, those statistically are more likely to present older, in your 20s, in your 30s. So any instance when you're dealing with early onset bipolar disorder, meaning under 18, you're talking about a statistically rare event. This is a neurologically vulnerable child who's probably been exposed to things in utero, genetically, situationally has been exposed to repeated chronic stress, which changes how genes act in your body. So because of that, I always look at it as you really don't know what is going on, because this is a young, evolving, growing, developing, emotionally, physically, all these things, this little person. So you don't know what you're going to end up with.
So Simone,
Sure.
Just for clarification, what you just said is that children with bipolar disorder is relatively rare.
Yes, I don't want people going in thinking that so many kids have bipolar disorder and 1 out of every 5 children who goes to the doctor is going to meet criteria for this, because only 1% of the population at all meets criteria for bipolar disorder. And it's a significantly smaller percentage is going to present, outside the realms, outside of the bell curve, which is when you're talking about peds. So, and bipolar disorder is, and really by that we mean mania, because that's what distinguishes bipolar disorder from unipolar depression, is the experience of mania or hypomania. When you think of really active, volatile, kind of screaming, yelling, easily triggered, distractible, wild, when you think of, that could describe to an extent normal child behavior. That could describe hyperactive impulsive presentation, ADHD. That could describe disruptive mood dysregulation disorder. That could describe bipolar disorder. I think because children just have a limited palette with which to express behavioral and emotional psychiatric conditions, so they all kind of look the same because they're only working with so much. Bipolar disorder, there's difficulty with diagnostic specificity, because isn't this something else that 60 to 90%, so essentially almost all kids who meet criteria for bipolar disorder are also going to meet criteria for ADHD, but that makes sense when you think about the cognitive and behavioral components to a manic episode. It's distractibility and it's increased activity. It's being pleasure seeking. Well, this looks good, I'm going to do that. Oh, this looks good, I'm going to do that. You can understand the overlap there. And actually, the brains of kids with ADHD and the brains of kids with disruptive mood dysregulation disorder, which we'll talk about in a little bit, they look similar. They perform similarly on tests that require sustained attention and deliberate shifting of attention. I mean, there's a reason why these look similar. The odds are better that a child has ADHD than that the child has bipolar disorder, statistically. So, but that doesn't mean that a mood disorder is not comorbid with ADHD or conduct disorder. That's a lot of overlap with bipolar disorder and conduct disorder. We'll talk about that toward the end. So scientists have really struggled with accurate diagnosis of bipolar disorder. This middle dot right here. If you know the symptoms that you're looking for, then you can see when the diagnosis is there. So critically important, first thing to recall, well, what is the symptoms of bipolar disorder? Well, it's a sustained period, and it's no different with kids than it is with adults as far as it needs to be a week, and it's excessive activity or grandiosity or irritability, except irritability is subjective. So what changed with the DSM-5 is that you really want to focus on a change in activity level, because that has been found to be more specific to mania/bipolar disorder than just, well, I feel so happy, or, oh, I'm just so irritable, everything makes me mad all the time. That's subjective. But you can objectively, you can have parents, you can have teachers, you can have football coaches, you can have cheer squad sponsors. They can say, your child is having, just for the last couple of weeks, seems to be having trouble sitting still, and she's getting into other people's business, and she's just kind of distractible and not following along with the group, and she's talking a little faster and just talking a little more, and those are you can see that. With bipolar disorder, because again, the criteria are the same for a 12-year-old as it is for a 32-year-old. The presentation will be different, but the criteria, meaning the symptoms that are emphasized, will not be identical, peds versus adult. But the core features, the primary features, it's the same thing. Sudden onset, not necessarily a change in duration of onset. There's so much variation with that, Sabina. That's a good question. But no, that's not a overnight kind of thing. What you'll typically see and what parents will tell you for kids who meet criteria for bipolar disorder is that when they look backwards, there's several weeks to months of some up and down fluctuation of kind of these excessive activity, not really meeting criteria for full mania, not meeting criteria for full depressive episode, but there's a gradual shift and increase to where they're just, if we're talking about mania, they're not sleeping as much. They're staying up later. They're getting up more in the night. So there's sleep disturbance. There's an observable change to activity, to their ability to follow through with tasks, like task completion, running out of the house before they got their shoes on, before they still have all sorts of things in the house, distractible, maybe blurting things out. Something that might look like inattentive ADHD, except the child is 14 and they've never acted this way before. So history is critically important. That's why you ask about parents. How were they young? How they meet milestones? How was starting school? How was experiences with friends? What's their normal sleep pattern? What's their normal activity pattern? What's their normal mood? How do they normally respond to changes in schedule or things with family, and what are their interests? Because you're tracking changes, and this is going to be a distinct change occurring over, not overnight, but potentially over weeks and weeks and weeks of a trend toward increasing activity. In younger kids, like 10 and under, you're not going to see, you won't necessarily see grandiosity, which you can in like, I am invincible and I am just awesome and I'm going to do something really great. Shift from the child's normal personality. 10 and under, you won't see that euphoric kind of things. In adolescence, so 12 and up, you're more likely to see this inflated self-esteem. You don't really see a shift in self-esteem in younger kids, pre-adolescent, but it looks really irritable. Nothing is satisfactory, easily frustrated, easily aggravated. Just a kind of a baseline irritable mood with sort of explosions that you may have, some intense yelling, screaming fits. Nothing outrageous, nothing that qualifies for other diagnoses that we'll talk about in a little bit. But it's kind of a baseline, increased activity, irritable, with some fluctuations. There will be normal days. That's another really important thing with bipolar disorder is when parents look back, they may say, yeah, there were a couple weeks where they were just busy, not sleeping as much, had to do some melatonin, talking a lot, interrupting, in and out of the living room when we're watching TV, those kinds of things. But then they sort of went back to normal. There's a distinction with bipolar disorder. This isn't just how the child is all the time. This is a departure from normal mood, normal activity. It fluctuates. It's not constant. So somewhere that we can get kind of messed up is, well, it seems like irritability is the symptom of choice for all pediatric disorders. Isn't that what depression looks like in kids? Just they're real irritable and disagreeable? Right, but that's a departure from normal. It's not just kind of the child's baseline. And with depression, that is not juxtaposed with periods of increased activity and talking a lot and kind of impulsive and distractible and just wanting to be suddenly really interested in, I'm just working on this hobby just all the time. With bipolar disorder, this isn't the child's baseline. It is a marked distinction. And it is going to be juxtaposed with experience normal sleep, normal activity, normal mood. So it's fluctuating. And again, this is not common. This is not a common diagnosis, but it does present in kids. So it needs to be something that you're alert to. But if parents come in talking about, oh, my child is just so irritable, and we can't console him or her, and little things make her just tremendously upset or make him tremendously upset, and we have trouble managing, which is probably what that would look like, then you would want to assess for changes in arousal, in activity, in awakeness, in distractibility. Is it showing up in other places? Because you would expect it to. This shouldn't just present at home. Teachers, coaches, neighbors, other people would observe this too. The problem with bipolar disorder is that I have broad spectrum phenotype here, is that researchers and psychiatrists and these people who work for the DSM said, we may need another category for kids who are irritable, but they're irritable all the time. I mean, it's been years. And these kids have these explosions of anger and temper, and they're inconsolable because just because kids have kind of acute moments of dysregulation and temper blow-ups, that doesn't make them bipolar. I think there may have been before the DSM-5, when we had disruptive mood dysregulation disorder, providers were forced to kind of make a diagnosis fit. And so you had a lot of kids diagnosed with bipolar disorder NOS and oppositional defiant disorder, because they didn't have another way to capture kids who were just sort of, they were kind of irritable all the time with the potential for big dysregulated, disinhibited anger outbursts. That there just wasn't a better way to qualify that. And those kids were really helped by mood stabilizers. So they kind of gave them a bipolar NOS diagnosis to justify that. Like Dr. Fogler saying, sometimes you need a diagnosis to justify the treatment. So just like with adults, you're going to listen for and assess for the primary features, the secondary features of a manic episode if you're considering bipolar disorder. Because ADHD, depression, I guess ADHD is not the best example, but you can say with depression, you can say with conduct disorder, with oppositional defiant disorder, there's not, in and of itself, there's not this activity difference. The being really distractible and differentially impulsive and talking too fast and just ideas nonstop, grandiose, this elevated self-esteem. You don't see that in conduct or oppositional defiant or disruptive mood dysregulation. There's not an intrinsic mood, euphoria, sleep. A lot of kids with ADHD have sleep problems, probably most of them do, but there's not a mood component inherent to the diagnosis of ADHD. So if you're talking about euphoria or grandiosity or periods of irritability that last for weeks and then go away or are constant, that's not specific to ADHD, so you're probably dealing with something else. So always consider what's the objective observable symptoms, and are they present? And for bipolar disorder, it's not going to be happy and I'm going to start 4 clubs at school and I'm going to, these delusions and things. That's not going to be present in younger kids. Younger kids, it's going to be distinct periods of irritability with some hyper arousal, be it sleep, be it increased talking, be it distractible, more active, more into things. Because ADHD doesn't come and go. Mania can, hypomania can. So that's ways to distinguish one from the other. But with adolescents, so 13, 14, 15, as this activity increases, you can see that starts looking a little more like bipolar disorder in adults. You have the potential for psychosis, for paranoia. That's not my medicine. Those aren't vitamins. That's my parents are poisoning me. Somebody's poisoning me. And if it becomes a safety issue, if the child is psychotic, if the child is, so impulsive, or the adolescent is so impulsive, really dysregulated, capable of violent behavior toward other people, can't keep themselves safe or other people safe, with behavioral interventions and hospitalization for stabilization would be important with mood stabilizers. And typically it is second generation antipsychotics is kind of the go-to for pediatric mania. And things that you want to, if you're suspecting mania, distractible, just totally into hobbies, and which comes and goes at weeks at a time. Because remember, mania is at least a week. Major depressive episode is at least 2 weeks. You're not thinking from one day to another. You're thinking more on chunks of time that are lasting weeks if you look backwards. That bipolar disorder, when it is preceded by a depressive episode, because it's typically preceded by a depressive episode. If you're working with an adolescent, you would want to ask the parents, you do a retrospective assessment for a depressive episode, just times of really low energy, don't want to move, feel like they're made out of lead, don't want to get out of bed, sleeping all the time. Because if that is present in the past, then that even stronger indicates, yeah, that is a depressive episode that you more associate with bipolar disorder, which tells me this is probably a manic episode. Mood stabilizer would be how you treat that, of course. This little slide, this is on the updated one. This is more for your reference, I think, than anything, but we just included the FDA-approved medications for mania, for bipolar disorder, bipolar 1 disorder for children and adolescents. It only goes down to 10, so that's the youngest. But that's still really young. That's a really early onset bipolar disorder. But this is just for your own knowledge, kind of starting doses, target doses. Most of the time, you're just going to start with the lowest available dose, and increase till you see effect. Typically, it's going to be 10 milligrams Zyprexa. I mean, that's low. That's middle for an adult. 2.5 for Risperdal. That's kind of that's not so bad. You think 3 to 4 milligrams for an adult. Seroquel, 50. And then over to the right, you just have some titration schedules. All of this information, that's going to be in your stall book. That's going to be if you Google FDA, Zyprexa, mania, you'll get the FDA sheet, and you'll get all the information that you need to know for the prescribing of that drug. So don't hesitate to just, or if you have Hippocrates or any of those apps. So antipsychotics, second generation antipsychotics, they tend to be better tolerated, so they're really first line. When from head-to-head comparisons, kids tend to discontinue Depakote or lithium due to either excess sedation, or with Depakote with younger kids, so that under the pediatric child adolescent population, there may be more at risk for hepatic injury or pancreatic injury, especially if they're on other medications, which is likely, because if the child's diagnosed with bipolar disorder, there's a good chance they're also being treated for ADHD or anxiety. Oh, psychomotor retardation, Sabina. Like when you see PMR, PMA, psychomotor agitation, psychomotor retardation. Yeah, no problem. It's just typically you think depression in adults, they can't sleep and they're restless and anxious, and it's with depression with bipolar episodes, it's often the opposite. They sleep too much and they have no energy and can't move. So lithium has been used for maintenance for mania, for bipolar disorder in kids. Mixed results. Sometimes it helps, sometimes it doesn't. You have to do the monitoring. You have to, education about diet and water and those things. So, plus it's not consistently beneficial. Depakote can be beneficial, in particular when you have children who are capable of real explosive, angry temper outbursts, Depakote can be really helpful in reducing those for kids with or without bipolar disorder. But the risk of liver injury seems to be higher in younger people than adults. So that makes it not your number one. So these second generation antipsychotics, they're effective, they work quickly. Of course, you're watching for the metabolic disturbances because that's the main side effects that you're concerned about with kids, and then the galactorrhea with the Risperdal in particular. But this is just a place to start. Now, something interesting is Tegretol, carbamazepine, is an anti-epileptic drug that's used for mania, but it has the side effect of causing destruction of white blood cells. So Tegretol has the additional risk of causing leukocytopenia, which has to be monitored for closely. That's another added step. Plus, Tegretol, like many anti-epileptic drugs, is a 3A4 CYP enzyme inducer. So if you, just something to think about, say you inherit a patient or you're working with somebody for whatever reason, that Tegretol is in the picture, then there's a good chance that other medicines that are metabolized by 3A4, like Abilify, that will be metabolized more quickly than you'd expect. So Tegretol interacts problematically with other drugs. There's the risk of infection. Just not going to be what you start with. You would start with one of these medications. Risperdal seems to be a go-to, kind of a big one. Pretty well tolerated. Is helpful for comorbidities as well. Let's see. The target range, finding with lithium, just one other note, is that the target range tends to be lower than for adults, more like 0.4 for maintenance, but 0.6 to 1 during the stabilization process. But again, that would be done, more likely to be done on an inpatient basis if other measures were just not sufficient. The evidence is mixed on that anyway. So main thing is going to be your SGAs. Let's see. And again, this slide was beefed up, but it is available as the updated one. So we talked about bipolar disorder can look just periods of irritability with fluctuations, changes in activity in pre-adolescent, and then it can start looking a little more like mania that we think about in adolescence. It's objectively observable changes in activity and sleep and speech. Let's compare that to disruptive mood dysregulation disorder. We got irritability here. We just kind of talked about that. Isn't that what depression looks like in younger people? Can be. Isn't that what mania, bipolar disorder, can look like in younger people? Yes. But what is different here, and the thing to take home, is disruptive mood dysregulation may be some in-between mood disorder category that captures what mood disorders look like in younger kids than it does in adults. Adults, we have mania, we have depression, things in between. This seems to capture what mood disorders look like in kids, maybe more than it looks like for adults. What the things to kind of, it's interesting, this didn't exist before DSM-5. We didn't have this disorder, this diagnostic category as a syndrome, grouped symptoms before DSM-5. And before you did, you had a lot of, bipolar, NOS, and ODD was the best thing that they could think of. to call it. What they have found is that since the addition of this diagnosis, obviously once this was added to the DSM, you have a steady increase in diagnosis of this, but there has not been a parallel increase in diagnoses of bipolar disorder. So it's as though once this became a way to conceptualize children's mood disorders, it's not like we're suddenly seeing mood disorders as a whole increase. Bipolar diagnosis rates have stayed constant, but this is becoming more commonly diagnosed. So maybe this is capturing some other facet of mood disorders as it presents in children that bipolar and depression were just missing. Because for all of these, you remember, it has to cause impairment. So this isn't just we're not trying to overdiagnose kids. We're not trying to pathologize children. Remember, they are evolving systems and organisms, and you don't know what they're going to end up being. Nope, there is still an oppositional defiant disorder. That's a good question, though, Sabina. This is like ODD plus. Let me catch a question from Jean. So they have to have 3 a week for 12 months and no more than 3. Right. So that's a good question, Jean. What they're trying to say is what distinguishes this from classic bipolar disorder is this is chronic. This is irritable, really disagreeable, dissatisfied, easily frustrated, really. All day, every day, for over a year. So you've had at least 12 months of this just constantly irritable. That's not how depression works. That's not how bipolar disorder works. These are fluctuating. These are episodic. There's periods of normal mood. With bipolar disorder, there will be periods of ups and distinct periods of downs and lots of time in between. Things changing on the course of a couple of months solid of meeting criteria for a depressive disorder, and then nothing, and then euphonic. There's no more than 3 months where the symptoms are not noticeable. Because if you're going 3 months without this irritability and temper outbursts, then you're probably looking at more of an episodic fluctuating mood disorder, like a depression or like a bipolar disorder. So that they just mean this is this child's baseline. So there's the irritability like static all the time, but then there are several per week, disproportionate, disinhibited emotion, temper tantrums, throwing chairs, pushing parents, kicking, slamming doors, punching walls, lasting 20, 30 minutes until they sort of poop out. Because you can only maintain, it's kind of like a panic attack, you can only maintain that amount of arousal for so long. So what distinguishes this, it can't be comorbid with ODD, because if a child meets criteria for this, then you can assume that any oppositional defiant behavior is just part of this. We're not going to talk about intermittent explosive disorder for the exam, but that's just essentially temper outbursts only without the irritability in between. That's what intermittent explosive is. And what distinguishes this from oppositional defiant, which I think is the next slide, is it's really, there's not that constant, unremitting irritability, and the temper outbursts are not quite so large. They're probably not as violent, and with some other changes. But with disruptive mood dysregulation, to rule out mania, you have to rule out any periods of mood elevation, any periods of hyperarousal, and the readings in SADC and THPAR and PINE do well to help with that differential diagnosis. I really like the SADC differential diagnosis sections in each little area. But there's no arousal, sustained arousal criteria with disruptive mood dysregulation. There's no, being real distractible, really suddenly interested in music and hobbies and art and sports and forgetting things and, forgetting, it's like not listening to instructions, there's no distinct periods of I'm suddenly real awake and real active and there's a change to how I'm talking and ideas I'm having. And so that's what distinguishes this from a manic episode. So if there is concurrent evidence of changes in arousal, meaning sleep, activity, thinking, then that's not going to be disruptive mood. So hopefully that makes sense. And this has to be present at least by age 10, but you don't diagnose before age 6 when irritability and temper outbursts, that's fairly normal until 3 or 4. So you don't really say, that's developmentally inappropriate. It's disproportionate to developmental level. Treatment for this. These are just some things that you can jot down. With any pediatric disorder, there's a really good chance that family, environmental, situational factors are contributing, if not necessitating, the behavior. So first thing is always an assessment of the system the child is in. Do the parents act this way? Has the child been exposed to abuse, to violence, to multiple placements? Is the child in, a foster care situation? Was the child pulled from a home because it wasn't safe? What have they been exposed to? Because that changes what their behavioral template is going to look like. So you assess for that, those kinds of risk factors. And you have to, in our instance, we would probably refer to a therapist or a behavior analyst or a social worker to try to install some different parenting behaviors and different structure and different reinforcement programs, and improving communication and helping the parents respond differently to these behaviors. So that's critically important. But even still, sometimes the explosiveness, the child can't manage it, and they need help chemically to decrease the size of the anger outbursts that happen. And second generation antipsychotics are a good start for that. There's no meds, nothing's FDA indicated, but research shows that second generation antipsychotics, in particular Risperdal, can reduce just the baseline irritability and the frequency and intensity of the outbursts. It can actually improve depression too, because those SGAs have some mood elevating qualities as well, which may also speak to there's a physiological relationship between this disorder and bipolar disorder, in that medicines that can lift mood for people with bipolar disorder, your Seroquel, your Risperdal, can have the same effect for children and adolescents presenting with this. So there's no arousal issue. They're not meaning for mania for these reasons. And it's much more chronic. This doesn't fluctuate like Jean was pointing out. This doesn't fluctuate. DBT, dialectical behavior therapy, has been adapted for use with children and adolescents, and that has shown a lot of benefit for improving the irritability and the outbursts. And DBT is all about emotion regulation and risk reduction and planning what'll happen, how to avoid situations that cause it. how to respond differently. So no surprise that DBT is helpful. Some studies show that methylphenidates for some kids are helpful. What you can have is kids with ADHD, a combined presentation that you address with a stimulant, but these disorders, these symptoms persist, which speaks to the need for, you treat one thing, and if something else may become evident or something else may persist, well, that just means that's a comorbid condition. So you would treat both. Studies are also trying to see are SSRIs going to be helpful for this population, but the jury is out. These are more recent studies. This diagnosis just came out in 2013, so nothing FDA indicated, but second generation antipsychotics seem to be helpful. Sabina was asking about ODD. Well, what about ODD? This is very similar to disruptive mood dysregulation. Irritability is pretty prominent, but it's not constant. And the temper tantrums are not as severe. So to an extent, it's a severity distinction between the two. And something else, Sabina, have you worked with many kids with ODD? Or anyone else worked with many kids with ODD? Adam has. Any primary, Adam has a lot. Anything like one hallmark feature, just wondering if you had kind of a hallmark standout feature or two of those kids, or Sabina, where you're working now with ODD. Lots of defiance. Defiance of staff. You're not the judge of me. You're not the boss of me. Sure. Yeah. Oppositional defiant disorder often seems to come out when rules are being applied. So it's almost more a reaction to the system than it is disruptive mood. There might not be a real apparent trigger, and it may not be related to rules and authority. It's more chronic, it's more baseline, whereas ODD can be seen as more reactive to something else that's happening. Jessica, you're seeing a good bit too. Yeah, there is interesting studies about the brains of kids with ODD and then with conduct disorder. There's differences certainly, but there seems to be a misattribution of a misinterpretation of anger or opposition. If you show kids who meet criteria for ODD or for conduct disorder, you show them pictures of people with different emotions, they tend to overinterpret anger or hostility in adult faces that are actually neutral, that other people would say, he looks bored or he looks sad. So there's an information processing issue that kids with ODD and conduct are hypersensitive to interpreting hostility when it's not there. So you have that, and that's related to brain structures that are associated with sensitivity to emotional content in people's faces and presentations and kind of interpreting emotional social cues. So there is a starting to find physiological basis for this opposition. Yeah, the ones that you've seen, it's like they can't stop it. It's as though they're reacting to something that's really there. It's as though they're responding to stimulus that other people don't see, but they're interpreting it as threatening or as hostile. ODD is highly comorbid with ADHD. And there's some interesting theories as to why that might be, that or just how, kind of generally, how oppositional defiant disorder may develop in kids. One of the main ones being if a behavior is reinforced with attention from a caregiver, then that behavior will be repeated. That's positive reinforcement. If you get something and you're more likely to do the behavior again, that's positive reinforcement. And one way to get attention from parents is to be defiant and to be disagreeable and to maintain an argument and to maintain that parental attention. So to an extent, the environment can promote oppositional behavior if oppositional behavior is rewarded with attention or emotional availability of the parent. So, and there's also kind of pick and fights is another thing. These kids are annoying. They will go and try to start stuff if nothing's going on. So it's almost as though they're trying to seek out a little bit of chaos. They're trying to seek out some emotional discord. Trauma mixed with trauma makes anything possible and everything worse is the problem with trauma. And it's kind of like they can't, like in their mind, because after the event they'll say, oh, I shouldn't have done that. I shouldn't have talked back. I shouldn't have done. They recognize they probably shouldn't have done it. So it's not like there's no remorse, there's no guilt, there's no nothing. That's a different story. But in the moment, they'll lie, they'll blame other people in the moment, but after the fact, they can recognize the behavior was inappropriate. So you can ask parents, do they ever apologize for what they do? Do they ever say that they feel bad? Do they ever say, yeah, no, that was wrong? That distinguishes oppositional defiant from conduct disorder. Because someone was mentioning, Jessica was saying, a lot of kids like to run away or skip school. That's another ball of wax. I think there was a reading. I don't think I have a slide. Oh, yes, I do. Yes, I do. Yes, I do. I think I do. Do I? I think I do. Yay. Okay. Hold that thought, Miss Fordham. So there's not a medicine for oppositional defiant disorder, because if there's a comorbid ADHD, absolutely you can treat that. And stimulants can improve oppositional defiant behavior because, like, they can improve anxiety, like they can improve any kind of impulsive disorder, because it improves the child's ability to regulate and attend to things and consider. It enhances, it can improve working memory, which is when you need multiple bits of information in your head, like what are the consequences and what happened last time I did this. You need to keep multiple pieces of information in your head to make rational decisions. So you can see that improve with this. They can self-regulate. They can stop and think. But what's really important is to change how the environment prompts and reinforces this behavior. So family-based interventions, improving parents' ability to regulate themselves, to recognize and respond to inappropriate behaviors, how not to make it worse, how modeling expressing needs, modeling identifying emotions, modeling emotion regulation, problem solving, have them provide more warmth and connection and availability more of the time. Because if a part of ODD is seeking out warmth, connection, availability that is not there, well, then how about you eliminate the benefit of this behavior if what it's trying to get is available already. Like kids who didn't have enough food growing up. This is a really sad parallel example, but overeating is a response, or hoarding food is a response exhibited by kids who didn't have enough food at times. There's no need to hoard and overeat if starvation is not an issue. So again, with all of these pediatric behavioral disorders like ODD and conduct, changing how the parents or how the system promotes the behavior is necessary. Communication, address comorbidities, sure. Yeah, I mean, so many disorders, it's an issue of impaired self-regulation and sustained attention and impulse control. And that's all frontal cortex. And that's not developed enough in these kids. So you throw trauma on top of that to further stunt development and connectivity of these neurons, and to keep the child kind of out of your frontal cortex, because that's what trauma does. Trauma says, oh, I don't need my frontal cortex right now. I just need my amygdala, and I need to be ready to fight and run all the time. I don't need to really think about anything else other than right now. So you keep kids in a trauma state. Oh my goodness, you're just keeping the most important part of your brain on the sidelines. So stimulants help because it allows those structures to start informing the behavioral responses. I have a real issue with kids on hospitals. So Sabina's seeing kids being discharged, little kids, so I'm thinking like 5 to 6 year old kids on Thorazine. Wow. Yeah, that's 6-ish. Antipsychotics, you'll read about Haldol still being used for kids. It stabilizes a mood. It limits the size of, it limits the magnitude of the temper outbursts. It's been around for a jillion years. It doesn't require a lot of monitoring. It's really available. So, I mean, if they're hyper aroused, in particular, if it's maybe this semi-bipolar, not sure if that's what it is, or excess activity is a problem anyway. Something working with kids who are really any kids, doesn't necessarily have to be inpatient, it'll be astonishing the number of medicines that the kids will be on. And sometimes that's due to corrections just can't be made in the environment to try to support, let's reduce the amount of stressors, let's reduce the stimulation, let's really reinforce and teach different coping. But, risk factors for all of these adverse childhood experiences are a risk factor for all of these things, in particular, oppositional defiant, in particular, conduct disorder. What distinguishes ODD from conduct disorder is what? Kind of how do y'all conceptualize that? What distinguishes conduct and ODD? Because they're different. I think Jessica had mentioned one thing earlier. The not going to school, skipping school, running away, those kinds of things. ODD is reactive, and it's kids, they're They can be argumentative. They can try to initiate arguments and defy, but it stops with really aggressive, physically violent behavior. That's not ODD. And it stops with harm, deliberate harm to other people, breaking rules, serious rules. Because with conduct disorder, and is this learned? Is this genetically predisposed? Both, probably. In the histories of children who meet criteria for conduct disorder, you see exposure. They have been exposed to physical abuse, to verbal aggression, no consistent caregiver, witnessing violence, chaos, just a constant upheaval state, a trauma state. And a lot of times the parents have substance use problems themselves, and they have their own histories of abuse. So to an extent, it's a cycle repeating itself. But the main thing is these are going to be kids and adolescents who just do not attend to the rights of other people, or kind of how society works. It's as though there's no consideration to other people or to society. There's no consideration there. Lack of empathy, lack of remorse. They don't feel guilty for things. That's different from ODD. That's different from all the other disorders. And it's interesting. You can have displays of aggression, a lot of impulsive behavior, dishonesty. So some things overlap with ODD, but this is a whole different thing, because there's a complete lack of empathy for people, consideration for rules. The part of the brain that you need to attend to other people's experience and how they might feel, or how things what they might be thinking in a certain situation, is undersized for kids with conduct disorder. The anterior insula, its job is it is active when you're considering, how might this person feel? I wonder how would I feel in that situation, or how might this affect them? Undersized. So it's almost, they have difficulty really empathy is not going to inform the person's decision. They just don't care. They also tend to have lower resting, conduct disorder is unfortunately what turns into antisocial. Yeah, conduct disorder turns into, when someone turns 18, antisocial personality disorder. They often don't have friends, they don't feel connected to people, they don't get excited about things, they don't get real sad about things. It's like someone who's been exposed to a lot of trauma. They're resting, they have less heart rate variability. A lot of these physiologic measures for people who've been exposed to trauma, like heart rate variability and the skin conductance activities and all those measures, they look like someone who's been traumatized, and they probably have been. But these folks can be, superficially charming and pleasant, but there's really no genuine emotion. There's no genuine connection. The animal torture that someone had mentioned, young kids with conduct disorder, they're not gonna, a 7-year-old is kind of limited in how they can display this behavior. So it may be pushing and fighting and bullying and those kinds of things, maybe stealing, violence against things that are physically smaller than them, like animals, precedes willingness of violence toward others, fighting with people, extreme forms of violence, murder. They don't, because folks who are antisocial, there's not a distinction between people and things. There's that lack of empathy that you attribute humanity to people. So things, animals, people, all about the same. Animal torture, young is fire setting, animal torture, so those are helpful questions or correlated with eventual diagnosis of. I'm not sure about the bedwetting. That is ringing a bell, but as far as something that you would look back and say, like a question that you would want to kind of litmus test for this, let me check on that. Yeah, if the amygdala and the hippocampus are small, if there's reduced gray matter in the frontal lobe, then that's not good. That's not good either. So yeah, Sabine, I'm glad you said that because that makes me want to go look that up. And to Kelly's point, not everybody with conduct disorder ends up manifesting antisocial. True. But people with antisocial personality disorder, if you look backwards, they had conduct disorder. If that makes sense. So folks with conduct disorder, when they're 15, 16, 17, 18, maybe they may end up being prosocial as adults. In particular, if you can change the environment, again, structure, rules. These are kids who might do well going into those outdoor camps, like I can't think of the name of it. Reality therapy, wilderness camps where you have to survive and you have to rely on other people, and you essentially form little mini societies for your own survival. So they may not end up with antisocial PD, personality disorder, but people with personality. Sabina, I know what upward bound is, but I don't think it's the same thing as outward bound. Yeah, Kelly, I'm gonna have to check with that. Now, it wouldn't surprise me if kids, a child with a trauma history who had bedwetting due to regression would eventually exhibit conduct disorder or, oppositional. That's possible, but as far as a physiologic mechanism linking the two, I'm not sure. Any kind of regressive behavior, like bedwetting after acquisition of that, skill milestone, however you want to call it, would be concern for what happened around that time. So social skills training, emotion regulation, second generation antipsychotics. Alpha-2 agonists like clonidine have shown to be helpful. Depakote has shown to be helpful. SSRIs has shown to be helpful. But this is so highly correlated with prior traumatic experiences. Probably the main, would this be a reason? I can see kids with conduct disorder coming into a psychiatric care as some sort of like legal diversion, school alternative school assessment, something like that. But you would know that there's a really good chance. I mean, you are an authority figure. So just consider working with kids with ODD or conduct, the built-in conflict for them working with you because of how they're going to view you. So anything that you can do to get them to open to talk at all? To try to trust you, knowing that they probably won't. And a lot of education for the parents. Deborah, are you asking me if I was thinking of Job Corps? Not necessarily, but just thinking of, parents will bring kids to you because of disruptive mood dysregulation disorder symptoms, of depressive symptoms, of anxiety that keeps them at home or makes them cry all day when they're at school. I don't know if parents would. I'm just trying to think of, I don't think I've worked with, I do outpatient, but I don't think I've, maybe oppositional defiance, sure, but as far as conduct, maybe only one child. And he was really there because he had ADHD pretty bad as well. Real quick, ladies and gentlemen. So you're working with Brad. He's 10. He has anger problems per his parents, and he will yell and throw objects, hit his parents, kick his parents, strike at his parents when he gets frustrated. He's 10. Does that sound developmentally appropriate? Right, okay. So, additional information. They describe him as angry, gets really easily frustrated. He's generally disagreeable, and he'll blow up, yelling, kicking, punching, several times a week. He generally sleeps well. Activity hadn't changed. Speech is no difference with that. He's still able to attend to things, finish tasks, pick up his room, get dressed for school. So what do you think? Karen suggests maybe this is ODD. This is admittedly not a lot of information, but the purpose is for us to just talk about it. By him sleeping well with no change to activity or speech or, organization, what does that rule out pretty much? No change to activity, speech, organization, sleep. What have we ruled out there? Okay, so this isn't, thank you, Kelly. We're not thinking bipolar, we're thinking something else. Developmentally inappropriate explosions several times a week, and he's generally pretty irritable all the time. Problematic at home, problematic at school. Okay, you're thinking ODD. What, Kelly's thinking disruptive mood. Right, and I acknowledge this is not exhaustive. We could go all over, well, I'd have to rule out this, and I'd have to rule out substance, and I'd have to rule out ADHD, so on, so on. This is beyond what you would expect with ODD, and these are, if this is untriggered, as opposed to just defiance when people are trying to tell him to do stuff, and annoying and irritable, and this kind of elevates you to more of a disruptive mood. He's constantly irritable. But, and if he is oppositional and disagreeable, you could just sort of assume that's that's part of this. So good. You're thinking ODD versus disruptive mood. You're thinking about what are the triggers, what are the scenarios, how big are the explosions, how consistent is it? And he's just generally disagreeable. Okay, so good thinking. Not good thinking. Brad, okay. Brad, here's another patient, Brad. Comes in with the same complaint, anger problems. He'll yell, he'll throw objects, he'll hit out at his parents when he's frustrated. If he was 3, not the hitting the parents. Parents have to kind of make this rein it in. Okay, but he's 10. They describe him as a loner, doesn't have a lot of friends, doesn't care about group stuff, what other kids are into, never really happy, never really excited. He's getting suspended. He's using substances, which is another huge thing with conduct disorder is substance use, self-medication. Right. So you see but this isn't ODD. I mean, he's breaking rules. He's not listening to his parents. But y'all wouldn't say that this is ODD. Clearly not. Y'all are saying conduct, right? Because this is an issue of rules, just not caring. There's also that sort of baseline kind of flattened lack of enjoyment. Hard to get them excited. It's hard for them to feel much of anything. Not unlike mood alteration that you see in post-traumatic stress disorder, difficulty experiencing positive emotions. Right. So very good. If it's legal, if it's fighting, if it's, yeah, good. Good, y'all. One more and then we'll wrap it up. So Brad, this is version 3 of Brad. He has anger problems. He'll yell and throw and become frustrated. Parents describe him as hyper since he's 3. Forgetful. Gets real upset, but then apologizes. What you think? He's constantly moving. He's constantly talking. He talks to strangers. He loses things. He's forgetful. This disorder was not covered this week, so don't try to make it fit. Sure, right on. That's it. I mean, this isn't enough. You would get more information to actually make a diagnosis, but just kind of ballparking it. Yeah. So these are three instances where the chief complaint's the same and the behavior is the same, but it can be from. So you see, kids have a limited palette with which to paint their behaviors, their emotions, their experience in the world. So anger problems can be conduct, can be hyperactive impulsive presentation, ADHD, it can be disruptive mood, it can be bipolar disorder, it can be depression, it can be all sorts of things. So you just want to keep the primary features in mind and what distinguishes one from the other. Is there a mood activity arousal component? Is it constant versus episodic? Does it come and go? Do they ever get back to baseline? So good work. Good. Fantastic. And last but not least, so we have an exam on Monday. We posted a study template in Module 2, which is, I think, really similar to what the objectives were. It's going to be 45 questions. And for the people who want, I think we've had 10 people say they want to come test at the School of Nursing. It'll be the same time we did it the last couple times. 3 o'clock in the Learning Resource Center. That's that building with the Einsteins. In 255, there's no computer, so you'll need to bring a laptop. And there will be a couple of us in there monitoring so that everything is square. But that's about it, y'all. Any questions? I really appreciate the feedback and the comments. Oh, one final comment to kind of bring it all back in is because you really don't know what the eventual presentation is going to be. Thapar and Pine talk about wanting to be very, very prudent in what you label kids with, because the value of a diagnosis is just because it points you to treatments that work. But keep in mind, you don't want to pathologize kids because you really don't know. So to just call it one thing and treat it symptomatically, it can be a really good thing, because you don't want to get these kids thinking, and the parents saying, "Oh my God, my child has a mood disorder or disruptive mood or opposition defiant. They have this horrible thing," and then that skews how other people treat them and how teachers treat them and how the child thinks about themselves. So there is a value to calling it something milder. You still assess the same, you still treat the same, you still monitor the same, but there is a value to not over pathologizing and saying, well, this child has ADHD and ODD and an unspecified mood disorder, when, maybe you could just call it ADHD, or you could just call it an adjustment disorder with mixed emotional features. You still treat it the same, but then the child goes through this developmental period thinking, this is probably temporary, I'll get better, family's going to work together and we'll get better. And then lo and behold, they do. But just consider, you may want to take a different approach than if you're working adult inpatient, when you want to put 6 diagnoses down there to justify different billing or something like that. Diagnostically, less is more. You may want to start low, go slow, even with your diagnoses, because you don't know what it's going to end up being, and consider the possible impact long term by labeling a bunch of labels when you're not sure. So that's it. Thank y'all for your participation this evening. I will stop the recording